Hello, everyone. Welcome to the TRT and Hormone Optimization channel. My name is Danny Bossa. I'm joined today with a very special guest from Michigan, Dr. Edward Lichten.
Welcome to this channel. I am Dr. Steven de Vos, the Lichten Dermatologist, and this is my bro science hunting partner Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe.
Click the bell button to get notified.
I also invite you to join my other YouTube channel, The Lichten Dermatologist. The link you can find in the description of this video.
How are you, Edward?
Really good, Danny.
Great. So a lot of guys have brought up his name. A lot of the doctors have brought up his name as well. He happens to be an expert, if you will, on using low-dose anabolics to treat different types of diseases, as well as improving health overall. So he's got a website set up that goes through all the different types of diseases, stuff like Crohn's disease or SIBO and whatever, and how his use those actually help patients. This is very, very outside of the box thinking compared to the majority of the topics we discuss. So for me, it's an exciting topic. I hope you guys are all going to find this very interesting. So, Edward, welcome.
Thank you. So you're enjoying? Well, you get more snow than we did, but we got about 5 inches. And
5 inches.
And yeah, just a little too cold to walk out the hot tub when it's 20, but hopefully it'll get a little warmer. Anyway, usual question that people ask me is, you've been a gynecologist for board certified gynecologist for, let's see, 40. This has been my 44th year. So how did that end up with testosterone? And what's interesting is, as a gynecologist, the key drug we use is a drug called danazol, been around since 1970, and it really is an anabolic steroid. But it's weak enough that every pharmacy have it, you even have it in Canada legally, and we use it to treat endometriosis. The point being, as a gynecologist, this was the drug we did the most work with, but the impression about why it worked, everyone just absorbed one idea, and I never believe what anybody says. So I went back and looked, and really it works very similar to a drug that's famous in Canada called stanozolol or Winstrol. It's just about 1/100th the time weaker. And this drug blocks estrogen and promotes testosterone. And if endometriosis is a disease of women where you're going to have too much estrogen, whatever that means, and more growth of disease, then doing something that's the opposite makes sense. Now, moving it, 40 years in the future, and I go through my menopause or low T at 40 with night sweats and hot flashes and no sex drive and 5 minutes of tennis, I'm exhausted and depressed. And one of my women patients, we're talking, she says, my husband has the same problems. He was 76 years old. I said, I'm 40, 76, I'm in deep trouble. So I went back biologically to look at the blood work. It looked like I went through a menopause, like someone had castrated me. And the urologist 35 years ago said, we don't use testosterone. Aren't you afraid about prostate cancer? I said, no, I'm afraid I won't live to be 42. So I found one guy who had started pushing testosterone in the US, went out to California, I was lecturing. And because endocrinology is what we do as gynecologists more than anybody, I knew more than he did within 10 minutes and came back. And I felt great within a few days just getting testosterone. But the testosterone creams stopped working after 6 months. I went to pellets. From pellets, I went to injections. And with the injections, testosterone was enough. I found there was Nandrolone or Decadurabolin. Then another patient told me where I could get the Winstrol. Then another patient told me where I could get the Anavar or the Oxandrolone. So I looked at the biochemistry of how and why they work. And along the line, men are coming in not telling me they have Crohn's or migraine or something else and putting them on the testosterone, as many of your listeners will say, gosh, you're right, I got less headaches since I'm on the testosterone. So again, back to the physiology, understanding what goes on, it basically comes down now after 40 years of doing this into two principles. One, the term we really should be using is bioavailable testosterone. You produce testosterone and 98% of it is tied up in a protein called sex hormone binding globulin, which no one knows how to treat, except danazol treats it, and Winstrol treats it. But when you knock out one of the parameters, the other one, your body has a ratio it thinks it wants. So I have to replace both the testosterone and the nandrolone to keep the bioavailable testosterone up, and I have to add Winstrol or danazol to lower the binding protein. So the average guy, we're able to quadruple his bioavailable testosterone within a period of 6 weeks. So if a guy is not doing well on testosterone, we can increase it fourfold. And this is the same principle going back to when we treated patients with endometriosis. We push the drug higher to get a better ratio to be able to treat people. So conceptually, being that Detroit's an automobile city, I describe the Audi dealership across the street as, look at how many cars you have and look how many trailers. It doesn't make a difference if you've got a lot of cars, if you have a lot of trailers. And what the research is showing over the last 50 years is the environmental toxins are all estrogen. And I have kids coming in with this ratio that looks no different than their grandparents. So you got 3 generations. The guy got through World War II, and then my generation and the generation after, and we all look the same toxic level. So I've got 19-year-olds coming in who are having erection problems and migraine and Crohn's and all these inflammatory diseases basically are because we don't have the chi or the energy to keep the inflammation down.
When you're talking about the ratio, are you referring to the testosterone to estrogen ratio?
I'm sorry. Free androgen index is the testosterone to the sex hormone binding ratio.
Okay.
Because the binding protein ties up 90% of the testosterone. So just a little change in SHBG and you wiped out the testosterone. So those people listening who are using testosterone cream becomes an estrogen. Estrogen stimulates a binding protein. And 6 months later, you say, why is the cream not working?
So why wouldn't guys with maybe elevated levels of SHBG simply not just increase their dose? Because that's what, like, I guess the general consensus in our group is, if you've got mid to higher levels of SHBG, you might need a larger dose to overcome it to free up more testosterone. I know in some places in Europe, a lot of the consensus is they try to lower SHBG to free up test.
Right.
We were always told that lowering SHBG purposely isn't always a good idea. Can you maybe shed some light there?
Well, I've been doing that for me for 35 years.
Okay.
So conceptually, what I found, and you'll see in the literature, if you keep pushing the testosterone up, the SHBG comes up because testosterone converts to estrogen and estrogen pushes up the SHBG, and your body has a homeostatic ratio that it has decided is normal. That's why I will both maintain the cars, the testosterone, and by adding nandrolone or decadurabolin, deca is not bound to SHBG. So when you add a little bit of deca, and I'm talking about 40 milligrams a week, which people will laugh at how small it is. My average man is getting maybe 120 to 160 of testosterone injection. And then the binding protein is blocked with as little as 25 milligrams of stanozolol in 1 capsule per week. And that way you've got both parameters. But some of the people in the US are pushing high dose of pellets. It's going to convert to estrogen. And back in the beginning, I got a couple of breast cysts from the conversion. And then you add one more drug. Then you're adding the Novadex derivative or Arimidex. And now you're blocking the estrogen because you push the testosterone up. And my idea, keep it simple. So actually, we have 1 or 2 pharmacies that are making injectable stanozolol. So I can mix test, nan, and stans and throw in some B12, and lo and behold, 1 shot a week, and you got everything taken care of. And you're not going to get the progressiveness that you need to keep pushing the test. Like everything else, I mean, we'll do testosterone a couple times a week, split the dose, but the nandrolone has such a long half-life that you can do it once a week. So ideally, pellets of testosterone And then the Nandrolone is a tiny injection, and the stand's either a capsule. And it's like, 1, 2, 3 all at one time, and you're set for the week.
And why the pellets over injectable tests? Is it just because you're typically injecting it several times a week, ideally?
Well, I'm injecting about every 5 days. Some of my patients are doing twice a week. The pellets, when you use them, and they're done right, and I have a company that makes up a different pellet. So the pellets you get 6 to 12 weeks, we'll say 8 weeks, but I have a new one where we're actually coating it with suture material. So we're actually going to get more than 3 months. And the level is flat for that period of time. You get a little peak in the beginning and then flat. And me, I don't want highs and lows. I mean, when you've been on testosterone for a long time, you have to be off it a while before you feel it, okay? But conceptually, if you don't have extra peaks, then you don't have extra conversion. But my binding protein has been at 11 for about nanomoles per liter for, gosh, at least 10, 15 years. I keep it right down there with the 17-year-old boys.
Okay. So would you say that there's a benefit? Like a lot of the guys in our Facebook group that are doing injections, a lot of them have come in where they started just doing like weekly injections. And then, it's like, I feel great at the beginning of the week, and then things just kind of go south. And by the, the 5th or 6th day, I start feeling like crap. So we got a lot of them doing frequent administration. Some of them are even doing daily administration. So they're just, they're doing 200 milligrams a week. They'll do 30 milligrams a day, tiny little injection. That's it. Keeps your levels consistent. So is there, in your opinion, a benefit of doing pellets over something like that? Or is it really just the fact of I don't have to inject myself?
Yes. It's more like I don't have to worry about the testosterone injections. I forget. And the other thing, if you're going to do more frequent injections, you're going to have less peaks. Okay. But you'll peak at least twofold, threefold where you'll be at the low point. So if I'm doing, 160, 180 of test, a lot of my patients are coming in close to 2,000, and that's probably a little too high. I like to see a serum testosterone could be 1,000, 1,200, and if I use a little less and they're having a problem on day 5 or 6, then I don't mind giving them some topical testosterone for a couple days, knowing that I've blocked the binding protein with the Winstrol. So what are you comfortable with? What works for you? If you don't feel depressed, I let them learn what it feels like coming down, and then they know when to intervene. And they say, well, I only want to do a shot once a week. Here's some cream. Or I don't mind doing twice a week. It doesn't make a big difference, but I don't like when the doctors load them up with huge amounts of pellets and get their testosterone level up in the 2,500s nanogram per deciliter. It doesn't make sense. Be physiologic, have some variation, but like I said, 1,200 should be about the peak on the second, third day, and then I try to drive it down to about 400. So their low point is still going to be above average.
400 would be their trough, if you will. You're saying once the pellets kind of start wearing down, if you will,
Right.
or
With the pellets, you can. You got to see what works. That's why I do frequent blood work. But with the pellets, the data says 600. I would go higher, 800 to 1,000 with pellets. You should feel really good. The pellets don't convert to estrogen as much as even the injections because they're not getting the highs and lows. But again, in time, and I've been doing this more than 30 years, everything was cool. And then one week, my estrogen level went to 60 from 20. My body just figured I was there. So I monitor the patients on a 3 or 4 month basis to get their PSA for medical legal. And they know to call me. And I teach them, just like your people know, what the modification is. But the idea that if you add some Nandrolone, that's going to free more testosterone, from the binding protein, so you get a little more kick. So 2 parts test, 1 part Nandrolone for me has been a real nice balance. So maybe 120 of tests, maybe 40 of Nandrolone, no sexual performance issues. And the blood levels are good, they're feeling good. And then the big trick is how to block the binding protein. because I believe that's the environmental toxins. And getting into the topic that we wanted to focus on was, well, how does this all fit? Well, the way I look at it is the environmental, and you have the problem with fracking, and they play down fracking, but what they're fracking with in Canada is a detergent, right? So for years I've said it. Now one of the companies came out saying it's a fracking. So the fracking is whatever it is, it's with the petroleum. You're getting these environmental estrogens, which are triggering the liver to make sex hormone binding globulin. And what happens is, as estrogens, they're going to suppress your normal pituitary function. I explained to my lay people, it's like taking a birth control pill. And studies years ago, the guy said, gosh, women don't get heart attacks. Let's just give the guys birth control pills who have had heart attacks. They killed 42 of 44 guys in 2 years. So it's not good for us to be on synthetic estrogen. For the women, again, you replace the natural estrogen with a synthetic. So when you take artificial hormones, it's going to suppress your normal production of total testosterone. And the researchers have looked at total testosterone, but they missed the concept of what's bioavailable. So all the articles have been screwy results. But when you take the two parts, your body's making less testosterone because the environmental toxins there, and the environmental toxins are increasing the production of sex hormone binding. Most guys are coming in with a 39% of ideal at 30. So it's 100% normal. And this work was by Anderson. It's called Free Androgen Index, data from 1972. Everyone's ignored it. But he said a little bit of estrogen, 1/20th of a birth control pill, will knock out 60% of the free testosterone. We're that sensitive. So knowing that's a factor, I want to make sure that the body is going to have adequate levels of testosterone. So we add the test, like you're doing, and a little bit of DECA or Nandrolone sticks in the receptors, frees the testosterone. And then on the other hand is I'm focusing just like Anderson did. You got to block the binding protein. So I call this ratio my chi, my energy, my repair potential. And as I found with women who didn't respond to Danacrine, and then what for me, go from last in my tennis league to first, at 52, not so bad. Just the difference of having what we're supposed to have in bioavailable testosterone. And when I treated the men who came in, their migraines went away, sexual performance got better, their arthritis went better, and then the diabetics, I showed that we could actually reduce insulin requirements by 50% back 20 years ago. You can't do it now, we're more toxic, but I get my insulin requirement patients down by 25 to 40% by giving them the energy. Because actually Nandrolone, not insulin, drives sugar into the muscle cell. Okay. And that's the parameter for diabetes. Now for the arthritis, we have I call it my immune totem pole. You've heard the terms, I'm sure, on TV, tumor necrosis factor for Crohn's. And these are the components of the immune system. And if, again, changing topics, which I do frequently, but one of the fellows researching, head of the program in Rome, identified that there were two like antennas on the nucleus. So in my day, we had a liver and the kids had liver enzymes. Now we're looking at what's happening right inside every cell in the body. And he found that when the lymphocyte, the immune system, lost this estrogen receptor beta, there'd be a flare of Crohn's. And the head guy in Madrid repeated it. I saw the article, I said, hey boys, you missed the link. Estrogen receptor beta needs testosterone. This is why when I treat Crohn's patients, just like we're described treating you for the mild cases, their Crohn's got better because we're shutting off the inflammation because you couldn't stabilize the estrogen receptor. So the whole new thing that's cool, and I think I told you I have a lab we put together at the University of Toronto that actually can measure the estrogen receptors on the nucleus inside your lymphocytes. And what that means is we have a score. You know, you look good. I cheat. My scores are good. So I'm at 100%. Someone walks in with diabetes, Crohn's, colon cancer, don't feeling well. We can actually measure to see what you need to get you back to normal. Now, the data shows that if you had Crohn's and the Humira worked for you, then you go back to homeostasis, and that energy, you know, I call it my anti-immunity gas tank's full. But if Humira is not working, why don't we add back the anabolic steroids? Except every internist that I've met is so afraid of testosterone, they'd rather cut off your bowel than give it to you. I don't know if you have the same problem in Canada, but
Yeah. Oh yeah. It's worse here.
internists are just, you know, I wish them well. I wish they didn't practice medicine, but that's just an aside, at least hormonal. And they can see the data and they won't do it. You walk in with testosterone level 190, they'll give you 3 drugs for your heart, but they won't give you testosterone. You know, and I
Gotcha.
believe what is normal is normal.
So you're not necessarily doing anything to control. You're not trying to block estrogen in a way of taking an AI or whatever. You're managing it in a completely different way.
Right. So here's the logic on that. The environmental toxin is a weak estrogen, and there's different affinity for the receptors. The point is to get into the cell, it goes through what's called an androgen receptor on the surface of the cell. And if you have too little testosterone, then the estrogens will stick, and then they can move into the cell. But if you have free bioavailable testosterone, which has 30 times more affinity for the receptor than estrogen, then you can be loaded with estrogen in your serum, but it's not going to get through the membrane. And that's my faux pas, that's my insight. So by keeping the SHBG down and by raising up the affinity with Nandrolone, we block out the environmental toxins. So the guys who've been getting sensitive nipples from conversion, they don't. So here I had 2 lumps in the beginning. Once I started the Winstrol, I haven't had a breast cyst for 25 years, and I don't
Gotcha.
take Arimidex.
And is that kind of a fixed protocol used on guys that come in? You'll be like, okay, I'm going to start you off right off the bat on 25 milligrams a week of Winstrol and 40, 50 or whatever Nandrolone, or is it case dependent?
I draw their blood, okay, and I gave you an average, which most guys tolerate really well, and then I get the blood test back. So I've got a nice young guy here. He's had some medical issues. Instead of having a binding protein of a normal young guy is 5 to 15. Most of my patients are coming in at 30. He comes in at 70. Okay, looks good, works out, but I want to go ahead and drop it down because of his underlying disease. So then I will increase the dose of the Winstrol. I have some people come in with a normal binding protein, 15, 20. They don't need it. So I do have some people who are just on testosterone injections once or twice a week, even without the Nandrolone. You find what's going to be the simplest, cheapest way of getting them into where they're comfortable, giving me reserve for when things change over time. But my stepson was 23, had a binding protein of 57. And his mom made everything fresh and whatever. And why was it there? I just think we're all just so freaking poisoned. I can't imagine how bad it's going to be in 20 years. But this, I feel, is a reprieve because we're keeping it from getting into the system. So the concept is you got the environmental estrogen comes in. It's messing up the top of the totem pole, which is the estrogen receptor beta, or you want to call it the bouncer. Okay, if you don't have the bouncer there, then all the bad things start being triggered. And if you lose the estrogen receptor beta, then the cytokines, interleukins flare. There you get your Crohn's, you get your diabetes, you get your migraine, and this whole totem pole is inflamed all the way down. And then I see the base of this to be the genetics. You have to be inflamed before you're going to get a genetic response. And while I might be more prone to diabetes and this lady more prone to migraine, it's a continuum. So first you get inflammation, then you get a genetic disease. If it goes long enough, the estrogen receptor beta goes down, colon cancer is on the slide. like we talked about, SIBO, gastritis, treatment, not antibiotics, give them immunity, give them the testosterone. Then you have the Crohn's, give them the immunity by building up the testosterone. And then this estrogen receptor beta will be even 50% lower in colon cancer. So maybe we're just treating one disease, inflammation. So
Right.
after treating all these crazy different diseases you see listed, it's all the same. Give us our testosterone that they don't want to give us.
What about for women? My wife had SIBO for a long time, and nobody could figure it out here. Everyone was completely in the dark, and she did her own research, and she started figuring out and started demanding the type of treatment. So, would it be the same for a woman that was this type of thing? Would it still be testosterone and whatnot, or?
Well, on my website, the one that's usdoctor.com, 8 letters, there's a description of a woman who had such bad endometriosis that Hopkins had her on morphine drip, never take her colon out. And that was 10 years ago, and she heard from a realtor friend of hers, came up here, no pain. And the amount of Nandrolone I used on her to raise the index 100-fold was 20 milligrams twice a week, which is nothing. And that was enough to stop her pain, stop her endometriosis. And so once a week, the Crohn's patient was severe. She got twice a week. But could have gone once a week. But I give them syringes, or teach them how to make up syringes of 20 of Nandrolone with the Winstrol. So you see the doses for the guys and the girls are really the same. Just 20 to 30, 20 to 40, depending on the severe cases, with 25 of Winstrol. That's the key to counteract the environmental toxins. And the men, of course, get high dose of testosterone. Women are more sensitive. Some people are giving 75 milligrams of testosterone pellets. Some women will use a topical. Others will take 10 milligrams of testosterone to keep their libido crazy. So, and then of course with the women, we use spironolactone, which blocks the conversion of testosterone to dihydro to minimize their hirsutism.
Okay.
But no,
So
women,
the Winstrol, just so we're clear, it's always pretty much as an oral.
well, in the United States, that's where it's at. I have a couple pharmacists, compounding pharmacists, who made it up as injectable, and sometimes because it's a suspension, it clumps. Okay, and I actually, for the first time in 30 some years, got an infection in one of these clumps, from injection. So with the oral, it's such a low dose, you don't have to worry about liver toxicity.
Okay, interesting. So the type of patients that come in to see you, is it mostly people with this type of inflammation caused diseases, or is it even just a typical guy? Feel like maybe I have low T issues, or I'm having sexual dysfunction issues, or are you treating just kind of a wide gamut of patients, or is it more of that? Are you hitting more that specialty of?
It basically depends. I've got a couple of my patients who are Super Bowl football players, and I say, you tell your friends that you're seeing your gynecologist, so, but the point being is handle testosterone just like any other medication. And yes, I have people get referred, I want to feel good, I'm in my 40s, 50s, performance in the gym, performance in the bedroom needs to improve. And you want to set the nice level of hormones there. And then I have the patients that are around the city, outside the city, because there's less, we'll say negative discussion about the crazy gynecologist. So people come desperate. I see desperate people from all over, like the one from Johns Hopkins, the one from Mayo, patients with heart failure. I took 2 patients that refused heart transplant, kept them alive 7 and 10 years. They had much survival on my therapy as if they had a heart transplant. And you specifically, with the Crohn's you have, that's 2 to 3 times more than we have, and you have 75 centers in Canada for treating Crohn's. The Humira is, 6 to 60,000 depending who's talking about it, and the price of these drugs, $1,500 a year. I would love to see someone knock on the door of the Minister of Health and say, what the F are we doing here? We got an answer right over here. These are FDA approved drugs. Yes, they're not legal here, but we don't have to be legal just to dispense them out of the 75 centers. The only people who could get the drugs. Why not do a trial? I've got, 15, 20 patients. The interview is on that site. I've got 2 patients with what's called short bowel syndrome. They've had so much surgery, they're down to nothing more than 14 inches of bowel. And they get fed with IVs. I've got 2 of them back to work. They won't say that the journals will publish it. They won't. But the point being is, this is an answer that we're really avoiding as the drug companies, rake it in.
Do you want to explain further the process you were discussing in the lab in Toronto? For just now, I'm sure people are saying, "Oh, I'd love to have my blood analyzed to see what kind of inflammation I have." So what's the process exactly? Say a guy like me just says, "I want to do this."
Okay, well, here's how it works. You draw blood from the arm, and the cells that are filtered out are called the lymphocytes. That's your immune system. Let's just say T lymphocytes. And the lab is able to grow the lymphocytes in cell culture. So now you got 10 test tubes with lymphocytes in it. Now, that special test that very few labs can do can look into the nucleus of the lymphocyte and measure that estrogen receptor, beta and alpha. And I told you, when you lose the beta, you've lost your functional immunity. So you can get a baseline. Then what we're doing for the first place in the world is we add chemicals, FDA-approved drugs, back into the aliquots. So if you were on Humira, the first tube might get Remicade, the second one may get Celebrex, and then I use the 5 anabolic steroids, and then we go ahead and remeasure the estrogen receptor beta. So if you had 40% on Humira, and you had 40% on Remicade, and you had 100% on Nandrolone, stanozolol, and testosterone, which one's going to work when you take it out of the test tube and give it back to the patient? So it's no longer try this drug. We're actually using the laboratory to determine which combination of drugs is actually best for you. And that's, I believe that's 20 years ahead, because no one wants to talk about it. They talk about with chemotherapy, which cancer is going to grow, which cancer is going to do better. But no one says, with biological system, how can we help the biological hormonal system? And our results have been so far really off the wall interesting. And anybody who has disease listens and wants to have this done, contact me. I mean, the cost is $3,500 to run the test, and that includes the 2 tests. But then I want to repeat this 8 to 12 weeks later after you've changed and you're now on the new meds. So if you were on Crohn's patient on Humira, you decide that the 3 of the anabolic steroids work for you, you would go ahead and then go on that if you were seeing me. And then we repeat it, 8 to 12 weeks later and say, hey, you were 40% when you started, now you're 100%. You were having 15 bowel movements a day, now you're 3, you've gained 15 pounds, you're playing, you're back playing hockey. That's what we want to do. We want to put a number in there, because the pharmaceutical companies don't want head-to-head comparisons. They want the doctor to write the prescription and then take it for as long as you can.
And is this often covered by their insurance or stuff, or is it usually just pretty much private?
This is all a private lab, and once we have enough data, we're going to try to get in the U.S. To start with, that this will be approved for payment. But the lab that I work with, she does work for the U.S. Army, drug companies. I mean, she's got something there. And she said, my idea of being able to test the drugs it's called in vitro, in the lab versus in vivo in life. She loves the idea. And I believe another year, 6 months, a year, we have enough data. It may change the direction. So why take a drug that's not going to work? And if a drug's not working, why don't you add one that will? I think every man and woman who has inflammatory bowel disease, at least should be started on both. because it's all inflammation, and the most anti-inflammatory product is not prednisone, it's actually nandrolone. It's more, and it's anabolic, so you don't weaken the bones. So it's my go-to drug.
Is there anything in particular that guys taking nandrolone for, therapeutic benefits or whatever should be looking out for in regards to blood work or whatnot?
Well, both testosterone and nandrolone will raise the blood count. So my patients, if they have good iron stores, end up donating blood. I mean, I gave a lot of blood in the beginning and just cut back my red meat and kept my ferritin levels under 50. And that's really number one. If you get too much nandrolone, of course, it can affect sex performance. So the key I say is a 2-to-1 ratio, which is 2 parts test, 1 part nandrolone or less. And then the people who are more inflammatory, we have 20, 40, 60 milligrams. You can keep increasing. I have very few people who have sexual performance, men who have sexual performance issues when you do that. And of course, the nandrolone, the women love nandrolone. They can outcompete with the men with their drive.
Interesting. Cool. So how would people go about reaching you for anything that you've discussed here?
Well, the website, usdoctor8letters.com, has all the topics we do. Of course, it's not that far to come. I mean, people fly from coast to coast, and I've had patients as far as Singapore. So the point is, the concept of what I'm doing with this is advanced, but once you get the blood work done, I have people from the United States that may see me every 4 years, and their doctor becomes my eyes and ears. So I've one patient, 72 pounds, cachectic in Washington State. She's 104 pounds on the program. So look at what's abnormal, and this high sex hormone binding globulin that people are just talking about. And I've been looking at this for 35 years and watching this number go crazy. That's the key. And the urologists don't know what to do with it. They've asked me, and patients call me up now saying, can you lower my SHBG? They're already so smart as to know what they're looking for. And the blood tests we can order, look at the blood tests, consult, talk, and then, we can get the drugs here because they're compounded and shipped to you. People have, one of my guys from Montreal has, he's now has a P.O. box in Lewiston or something, So, you get the medicines, we teach you how to use it, and, we say, be well and prosper.
Very good. Can you repeat the name of that website again, please? It came out a little.
Okay.
It was.
I'm the U.S. doctor, so it's USDOCTOR.com.
USdoctor.com.
Yeah, so it's got the phone number, email, and I'm all over the internet. You pick up a phone and call.
Awesome. Ed, I really appreciate the time you took here. I know that once this gets posted, there's going to be a lot of questions. So I'm surely going to be in touch with these questions. I'm finding so many different perspectives on a lot of this stuff. Like, we have one group that'll say, never lower your SHBG, raise your dose. You're like, no, you got to lower your SHBG for these reasons. And it's so interesting to see two different perspectives and their views and they can justify it. It makes things so interesting to me that I wonder if there's even one real right answer to anything.
Well, my answer is everything's good when you're not sick, but show me that you're taking care of the patients with Crohn's who are going to have their colon out, and the heart failure patients who get refused heart transplant. When you're treating at that level, if you're doing different from me, then that's great. But treating relatively healthy people is easy, okay? But when we're getting to the level where it's life and death situations, and as a gynecologist, I was used to, if you don't make the right surgical decision, it's a mess. But if you can take the sickest people, my rule, if you can take the sickest people and make them better, then everybody else is easy. So I've tried all these different alternatives back in the late 70s is when I started on this. And this just seems to work best. And I have some people who rather do sub-Q. That's great. And some people want to do Clomid and HCG. And I just follow their blood work. And as long as it's within range and they're not having symptoms, great. But I'm not going to treat a Crohn's patient with HCG. I'm going to use the stuff that I can load up that's going to change that ratio. And to me, it's all getting bioavailable testosterone, testosterone over SHBG that's compatible with a 25-year-old healthy kid.
Awesome. Really appreciate the time, Ed.
Yeah, fine. Just find someone to get me a meeting with the Minister of Health so we really can change the world, okay?
I'll work on it. Thank you very much.
Danny.
Really appreciate
Pleasure.
it.
Thank
Okay.
you.
Bye.
Bye-bye.